My name is Katherine Sabourin. I'm a PhD student at the University of Colorado, Colorado School of Public Health in the epidemiology program. And so I'm going to go through my project that I did this summer, which was in Zimbabwe, looking at risk factors for mortality for AIDS-associated Kaposi sarcoma. So Kaposi sarcoma is a soft tissue cancer. It usually appears as tumors on the skin or mucosal surfaces, and it can also be found internally, which usually has a worse outcome. KS is one of the top 5 most common cancers among both men and women in Zimbabwe. This is data from 2015, and the red arrow is pointing at Kaposi sarcoma. And 2016 is similar as well. I just wasn't able to get that data yet. AIDS KS specifically occurs when you have an individual with an HIV infection and a KSHV infection. So Kaposi sarcoma, the etiological agent is a KSHV, Kaposi sarcoma herpes virus. So you have to have this herpes virus in order to get the cancer. So when you have this co-infection, that's what leads to AIDS KS specifically. There are over 1 million Zimbabweans living with HIV infection, and up to 50% are estimated to be at risk of developing this cancer. So a big public health burden. In addition, the pilot data from the study data that I'm using found a 37% mortality rate among these individuals in primary care HIV clinics. So, high mortality rate, large public health burden. So that led to my research question, which are, what are the risk factors for death among Zimbabwean adults with this AIDS KS? And to answer that, I'm using data from the SECO study. So SECO is the Strategies to Improve KS Outcomes in Zimbabwe. This study was originally developed as an intervention for healthcare providers in 8 different hospitals, 4 rural, 3 urban, and 1 peri-urban hospital. The interventions were meant to help healthcare providers be able to better identify KS, and then also how to integrate care into those patients, just general care for the KS specifically. But as part of that study, any individuals who were previously known to have KS or were identified as having KS during the study were asked to enroll into this KS registry, where they had just some basic enrollment data collected and just kind of like, seeing how many people were actually had KS who were being involved in this. At enrollment, there were a series of questions asked about demographics and medical history, and then some were actually followed up, and this KS registry had over 1,000 patients. So it's a nice big data chunk for me. So the enrollment data included all of the exposure data that I want to look at for this mortality, for risk factors for mortality. I'm not going to go through these specifically, but just demographic data, and then also some medical data, medication use, and then some information about the actual KS disease of these patients. So those are going to be my exposures that I look at. So the big question, the reason why I went to Zimbabwe was because we needed to figure out vital status. So where was I going to get this mortality data from? In order to do that, I propose linking national data to the study data. There were some individuals who had vital status collected during the registry study or during the SECO study itself. Since the SECO study was ongoing, if patients came in or if they were known to have died, then that was collected. I also realized that I needed a lot more information. They did not necessarily have national ID numbers, which is what I needed to link the data to the cancer registry and to death registry. So we did some medical record review at the Peri-Nyatwa Hospital, which is the primary KS center for the northern 2/3 of the country, and it's really I think the only KS clinic in the country, but it primarily serves the northern 2/3. So we were able to go through medical records with that. We also did follow up with some of the other enrollment sites. So here I have a couple of pictures of the enrollment sites that we were able to actually physically go out to, which was really cool to see all the differences. A lot of the times you just kind of went and talked to the people in charge and they were like, oh yeah, that person's alive still, that person's alive still, or no, that person passed away. But if we weren't able to get it that way, then they had records that they kept on hand. So, using all of that, and then we would also go to the National Cancer Registry, which was in the Perry hospital complex, so it was nice. I could just kind of walk right over there and talk to people about it. And then we also used Zimbabwe death registry data. If we couldn't find their vital status from anything else. So really an exhaustive, we really did like everything I could possibly think of outside of, like calling people or physically like going to their homes to figure out what the vital status was. And using all of this, we did identify up to 80%. Sorry, I'm coming down with a cold, so talking is hard for me. We identified vital status for 80% of people. This data is not cleaned yet, so it might be a little bit less than that, but I also have more data coming in from the hospital, from some study staff who are still working on it. Sorry. I was collecting data until the very last day that I was in Zimbabwe. So, but I feel like this was a really good chunk. And again, I think we did as much as we could and really couldn't think of any other way to get this data than all of the things that we did. As far as future analyses, just my method. So I'm going to use all of that exposure data to look at which factors affect mortality. And this is all-cause mortality. I don't have specific mortality for AIDS KS. It would have to be all-cause mortality. I'm just using a survival analysis, which sounds very straightforward, but then once you actually get into it, it's going to have tons of really fun components for me to learn about. As far as my learning experiences, this is this is a picture of where all of the medical records are kept in the KS clinic. That's Kenya's digging things out and putting them back. Everything's paper at the hospital as far as what I could get my hands on. But I was able to, I learned a lot. I was able to identify how the cancer registry worked. I learned a lot about that. I think the cancer registry in Zimbabwe is one of the better ones on the continent. They do a lot of work, both active and passive, to get information. I learned how difficult it can be to try to link study data to registry data. Really learned about the differences in how you study cancer in sub-Saharan Africa and the treatment of cancer. Learned a lot about the collaborations that the study staff for the SECO study had with all of these other hospitals and with the registry, and really learning how to apply my epi methods to this data. I had a ton of ideas. If I sat down, I could brainstorm and be like, oh, you could do this study or this study or this, just working with this site. But I think that one of the big things is going to be access to care. I think that's going to be one of the biggest factors. And in fact, we don't have data on this, but anecdotally, I think one of the biggest factors is people just not being able to pay for their chemotherapy. I just find that that's, when I was there learning about what was going on, I think that's a big one. People can get to the hospital, but then if they can't, if you don't have the $20 or $30 for the chemo treatment, you're not going to get it. I think is really one of the big factors. Looking at effects of traditional healing, which is still definitely a big thing in Zimbabwe, on clinic attendance and mortality rates. Are people not coming to the clinic because they're going to traditional healers? We don't have data on that either, but I think that would also be fascinating. I think you'd learn a lot from it. Medical record consistency. I was already talking to somebody about this. Everything is handwritten. Things get copied over incorrectly. I mean, even within one patient's records, you can see like that CD4 count date is totally wrong from the other one, or like the number's wrong, or just things like that. So looking at that would be really cool. There's the opportunistic infection, like HIV clinic data. I think I haven't been able to look at it, but just kind of from going to the clinics and seeing, they have these green books everywhere. I think I bet there's some really interesting and probably relatively complete data in there, especially if you want to look at KS, because KSHV is, at its core an opportunistic infection that leads to this cancer. So that's an idea. And then who's missing from the National Cancer Registry and why? I was only really able to identify a third of the study population in the cancer registry, and I'm not totally sure why that is. If it's name change, perhaps people got married and changed their name, but I don't think that should account for 2/3 of them. So kind of seeing why that happened. Limitations of the study. So this is where all of the SECO data is stored. The first week I got there, they're like, oh yeah, we'll show you where all the records are. It's a storage unit now, like we had to climb over a bunch of stuff. Yeah, it is what it is, but paper records are obviously a limitation. It's harder to get through paper medical records, although the National Cancer Registry was electronic, so that was very nice. Like I said, inconsistent medical documentation is really difficult to deal with. If the birth date is wrong on 2 pages of a patient's records, which one do you use? Do you just kind of try both and see which one works? Also, people not putting dates. Patient came in, you don't know what date it was. Was that last week? Was that last year? It makes it really difficult. And then I think this is going to be a reoccurring theme with everyone, just time in general. Time works differently outside of the US than it works in the US, right? Everything's a little bit slower. You have to accommodate and plan for that. And it always seems like it's going to be easy until you get into it and you realize how much more difficult it's going to be. Strengths. The staff who worked for the SECO study were great. Everybody I met in Harare was just so helpful and really willing to, work with me on whatever I needed. The collaborations between the rural and urban hospitals, one of the SECO nurses took me out to all the sites, and they all knew her because she was pregnant when she was doing the study a couple of years ago, and they were just all very helpful. Nobody was like, no, we don't have time for that, I think Zimbabwe in general is a really great country for that. Like I said, the registry records were electronic, which was nice because I could get into it a little bit easier than having to pick through, 800 to 1,000 paper records. And the cancer registry has both active and passive follow-up. And then Harare is just a really great city to be in. As far as Africa, it's the third place that I've lived, and I felt the most safe there. And I just think anything you needed was within reach very easily, So it's just a good place to be if you are a student studying. So as far as my career goals, I'm going into my 4th year. I would like to graduate by December of 2019. We'll see how that works out. After that, I want to work in applied infectious and cancer epidemiology, specifically in Africa. So I was telling somebody I was originally an ID person. I'm still an ID person, but I really like the kind of non-traditional ID and how it affects cancer. So KSHV obviously is a virus. KS is caused by this virus. What are we missing? We know about HPV and cervical cancer. We know about all these different relationships that are coming out, and I just find that really fascinating. And I specifically would like to continue working in Africa. I love being in Africa. I think there's a lot of good that can be done there. And then working at a government or international nonprofit would be great, some sort of organization where I could do research and really just, at the end of the day, to be a leader in my field and to be able to teach people the skills that I've learned and to kind of continue on, with good epidemiology. So I'd like to acknowledge a bunch of people. So Dr. Barak was my in-country mentor and supervisor. She was great with like pushing people to help me out and getting everything done. Dr. Campbell was a co-PI on the SECO study, is also on my dissertation committee. Dr. Rochford is my dissertation mentor at University of Colorado, so she's obviously a big help, and then my other committee members. And then obviously the SECO study staff, Marcia was just phenomenal. She, really the time you asked her to do it, she got everything done. She was really on the ball. And then the Zimbabwe National Cancer Registry staff, Eric and Mary, were both amazing, letting me get into the data set and look at it and answering all of my questions. So, a big thank you to everybody. Okay, anybody have any questions?
One of the things that may be news to the group is that the N in National Cancer Registry is a misnomer. It by no means covers the nation of Zimbabwe.
Yeah.
It only covers people who actually live in Harare. So it's a population-based registry that requires you be a Harare resident. So the ZICO registry, which is basically a hospital-based registry, it's not population-based at all. And you mentioned it covers all these hospitals, and you were querying yourself as to why there were so many people missing from one versus the other. But I think the answer is that the Harare registry isn't a national registry, it's a city registry, basically.
Yeah, I mean, even when I was going through it, I definitely did see people who had other residences outside of Harare. So Bulawayo is like super far away from Harare, but I think that is a big piece of it, absolutely, because they do active follow-up on all of these individuals as well. So if they can't confirm it,
because it's the capital, it's not uncommon in
that they
cancer
would be in it.
registries for people to come to the city for treatment, and they have a cousin, they put the cousin's address down or something, and they somehow work their way into the registry. But those people should be excluded from the registry for the registry to be a population-based registry in terms of the calculation of cancer rates and that sort of thing. So I think that you're probably going to get, the ZICO registry is going to have many, many more people from all those outlying places that aren't even supposed to be in the so-called National Cancer Registry. So I think one of the things you might want to do is really focus upon the ZICO registry that covers Harare. That, the rest of them is good information, but that's the only registry, the ZICO registry, that you're going to be able to actually get good linkage to the Harare population-based cancer registry.
Okay.
Because they have, and you mentioned that they have 1,000 people in the ZICO registry. In the Harare Cancer Registry, there are probably 800 KS patients a year registered in that registry. So there's a lot missing from both places, but I think drilling into Harare would be worth thinking about.
Okay. No, yeah, that's a great idea.
Other questions, comments? So I have a question.
Yeah.
I think this is very typical of Africa and getting incomplete and inconsistent data from different sources, which is really interesting.
Yeah.
I wanted to hear more from you about the HIV registry, if they have HIV registry in Zimbabwe, and how this registry helped or could help your data linkage.
Yeah, so I'm surprised that I should have dug a little bit deeper into that. So I think that that's probably one of the best places to get the information, and nobody really told me about it, that existed. Like I said, I mean, when we finally went out to the sites, which was at the very end of my time there, I mean, everybody, they had all these electronic records of all these individuals who come in for HIV care. And like I said, I think that there's probably a lot of really good data in that. I just didn't know that that's where I should have been looking. But I think, I'd never really dug that deep into it, but I think that would be a really good resource. It's also electronic too, so it would have been really much easier to do than me trying to dig through paper medical records the whole time. If I needed more information other than vital status, I definitely would have pushed a little bit more for it, I think. But since I just needed vital stats, I think I was doing pretty good. And since we did go out to the clinics, I think I got as much as I could have from them. But yeah, no, I think the HIV data, because it's got so many different funding sources as well, is probably some of the better data that you're going to find. For sure.
Thank you.
Yeah.
Okay.
Thanks.